Welcome back guys. Now in this video, let's discuss a few more important pathological correlations. Okay, already we have seen about Liddle syndrome. Okay, we are going in a sequence. We have seen a defect in the sodium chloride, like sodium potassium 2 chloride importer defect, this is a Bartter syndrome. After that we have discussed about a defect in the sodium chloride importer, that is the 𝐒𝐫𝐢𝐻𝐿 syndrome. Now after that we have discussed about abnormalities of the epithelial sodium channel, okay, overactivity of the epithelial sodium channel which is causing the Liddle syndrome. Now in this video, let's discuss about a disorder called as a Conn syndrome. Okay, now what exactly is this Conn syndrome? Simple. In Conn syndrome, see, here is a tumor. Okay, there is a tumor. Now where exactly is this tumor coming? Now this tumor is coming to the adrenal gland. Okay, this is the adrenal gland. Okay, now in this adrenal gland there is a tumor present. Now I am saying it's tumor, not a cancer, because okay, this is not a cancerous condition, it's just a tumor. Now what this tumor is producing? This tumor is producing excessive amount of aldosterone. See, everywhere there is aldosterone. So excessive amount of aldosterone because of adrenal adenoma. Okay, this is adrenal adenoma. Adenomas are not cancerous. Okay, so excessive amount of aldosterone is coming. Now, see what exactly is Conn syndrome? Conn syndrome is adrenal adenoma producing excessive amount of aldosterone. Now in this patient, see, imagine that I am the patient who is having adrenal adenoma. So, aldosterone levels are going to be increased in my body. So, what is this aldosterone is going to do? We all know what are the three important functions of aldosterone. The three important functions of the aldosterone is sodium reabsorption. So, now in this condition, there is excessive amount of aldosterone. So, there is excessive amount of sodium reabsorption to the body. So, that causes increased sodium reabsorption because of excessive aldosterone. We also know aldosterone throws the potassium out of the body. And in this condition, excessive aldosterone, excessive potassium loss, that will cause hypokalemia, excessive potassium loss. And we know aldosterone will cause proton excretion, okay, H plus excretion, acid excretion. Now in this patient, excessive amount of aldosterone will cause excessive amount of proton loss. Excessive amount of proton loss means that will cause alkalosis, okay, alkalosis. So these are the clinical features in the patient who is having Conn syndrome. So in Conn syndrome, the clinical features are because of the excessive sodium reabsorption, that will cause hypertension, because of the excessive potassium loss, that will cause hypokalemia, and the proton loss will cause alkalosis. Now if you are really good student, you will have little doubt inside your mind, you should get a little doubt. So previously what we have discussed about? We have discussed about a syndrome called as Liddle syndrome. See, even in the Liddle syndrome, the patient is having hypertension, hypokalemia, alkalosis. Even now we are discussing about a condition where hypertension, hypokalemia and alkalosis. So then what is the difference between Liddle syndrome and Conn syndrome? What is the difference between the Liddle syndrome and Conn syndrome? Yes, etiology is different. There it is overactivity of the epithelial sodium channels. Here it is adrenal adenoma, tumor is there. But please concentrate, in Liddle syndrome, the RAS pathway is inhibited. So what happened to the aldosterone levels? Aldosterone levels are less. The aldosterone levels are less in the Liddle syndrome, but here the main problem is with the aldosterone. Excessive amount of aldosterone is there, okay, because of the adrenal adenoma. First of all, the aldosterone levels are more. So this is how to differentiate between the Liddle syndrome and the Conn syndrome based on the aldosterone levels. So please concentrate, see, so in both the Liddle syndrome and Conn syndrome, okay, there is hypertension, hypokalemia and alkalosis, okay, with low renin levels. But now what is the difference? Difference is aldosterone levels. Aldosterone levels are elevated in the Conn syndrome, but they are reduced in the Liddle syndrome. This is the important difference. Okay. Now after this, let's see what is the treatment of this condition. The treatment of this condition is, see, now normally you need to do the surgery. You need to take out this tumor, but surgery is not the option every time, right? So okay, let the aldosterone be there. Okay, let the aldosterone be there. Now what you can do as a doctor, you can inhibit the aldosterone receptors. Okay, you can inhibit the aldosterone receptors. How can you inhibit the aldosterone receptors? By giving aldosterone receptor blockers. Okay, simply something like that, or aldosterone antagonist. So what are the aldosterone antagonist? Aldosterone antagonist, here it includes spironolactone. So spironolactone is a aldosterone antagonist which is used in the treatment of Conn syndrome. It's used in the treatment of Conn syndrome, and this aldosterone antagonist is a potassium sparing diuretic. This spironolactone is the potassium sparing diuretic. Why? Because the other diuretics, the loop diuretics, thiazide diuretics, the one important common feature of both loop diuretics and thiazide diuretics is usually diuretics will cause excessive loss of potassium in the urine. Okay, they are potassium losing diuretics. But this speciality about this spironolactone, the speciality is the spironolactone will cause potassium sparing effect. Okay, less potassium is going to go in the urine. Okay, so potassium sparing diuretic. But one important side effect of this spironolactone is, whoever use this drug, spironolactone, they will develop the breast. That is gynecomastia. Okay, gynecomastia. The side effect of the spironolactone is gynecomastia. Why? Because the spironolactone is not only a potassium sparing diuretic, or it's not only aldosterone antagonist, but it is also an anti-androgen. It's an anti-androgen. Okay, so because of that, it develops breast in the males. So gynecomastia. Here itself, I want you to know this important mnemonic which is called as a DISCO. Okay, this is DISCO drugs, DISCO, DISCO drugs. Now these DISCO drugs, what they will do? All of them, they are going to cause gynecomastia. Okay, so these DISCO drugs are going to have a side effect of gynecomastia. Now what are these DISCO drugs? D for digitalis. Okay, digitalis drugs like digoxin, digitoxin. Okay, in the cardiovascular system, in cardiovascular pharmacology, you will study about these drugs. Digitalis. Now what exactly is this digitalis? Digitalis is a positive inotrope. Digitalis blocks sodium potassium ATPases. So what happens? Now they will increase the intracellular concentration of calcium. So the heart is going to contract more powerfully. It's a positive inotrope. Power of contraction, the power of the myocardial contraction increases with the digitalis. Okay, just reminding you, like just pharmacological integration. And isoniazid, what kind of drug is isoniazid? Isoniazid is antitubercular drug. Okay, it is ATD. Okay, it is antitubercular drug. We all know, HRZES drugs. HRZES. H for isoniazid, rifampicin, okay, pyranzinamide, ethambutol, streptomycin. All these are the antitubercular drugs. Important point is this, yes, this isoniazid, this H for isoniazid. Isoniazid, whenever you use this isoniazid, yes, it causes the gynecomastia. But one more important side effect is there which you need to know as a doctor. This isoniazid, it will cause vitamin B6 deficiency. Okay, it will cause vitamin B6 deficiency. So whoever are using these antitubercular drugs, they must take the vitamins. They must take especially the vitamin B6. Otherwise, they will develop peripheral neuropathy. Okay, that's a very important side effect because of the antitubercular peripheral neuropathy. Okay, so that they will be having numbness around the lips, they will be having tingling sensation in the fingers. All these are the features of peripheral neuropathy. And spironolactone, just now we have seen. So spironolactone is a anti-androgen or aldosterone antagonist, potassium sparing diuretic. Yes, we have seen. And what is the cimetidine? Cimetidine is a histamine receptor blocker. It's a H2 blocker. Okay, even in gastrointestinal system we have discussed. It's a H2 blocker. Okay, cimetidine is a histamine receptor blocker which is used for the treatment of peptic ulcer disease. It decreases the acid production. Okay, decreases the acid production. Now estrogens, estrogens are the ones which stimulate the breast development. So taking the estrogen drugs or estrogen like drugs are estrogen receptor modulators, they will also cause the gynecomastia. So these are the drugs which will cause the gynecomastia. So it's little bit pharmacological integration. So now after this, let's discuss about a phenomena which is called as aldosterone escape phenomena. Okay, so aldosterone escape phenomena. So what is this aldosterone escape phenomena? First of all, my question to you. Aldosterone, what it will do, whenever there is aldosterone in your body, okay, aldosterone, whenever you have aldosterone in the body, aldosterone will increase the sodium reabsorption. Every student knows. So whenever you have aldosterone in the body, so more sodium should be there in your body. Okay, more sodium reabsorption should happen in your body. But something different happens in Conn syndrome. So what is that? See, yes, in Conn syndrome, adrenal adenoma is there. Now what this adrenal adenoma is doing? This adrenal adenoma is increasing the aldosterone level. See, it is increasing the aldosterone levels. Okay, so more sodium is getting reabsorbed into the body. So wherever sodium goes, water follows. So more sodium reabsorption, more water reabsorption. So more sodium is there inside the body, that increases the BP. Okay, well and good. That causes hypertension. But important point is sodium is increasing the blood volume. Okay, sodium reabsorption, water reabsorption. So sodium is there in the blood, so it will cause volume overload. Wherever there is sodium, it will attract the water. So from the tissues, water is the fluids are coming into the blood. So what happened to the blood volume? Blood volume increases. That is the first important point. So blood volume increases. Now whenever the blood volume increases, what happened to the venous return to the heart? Now you are having more blood volume. So more blood is coming to the heart. Okay, so increases the, whenever you have more blood volume, increases the venous return. So venous return is going to be increased. Now when venous return increases, what happened? More blood is coming to the right atria. Okay, more blood is coming also to the left atria. Right atria and left atria, now they are getting more and more blood. Why I am specifically talking about the right atria, left atria? Because now this atria, inside the atria, there are volume sensing receptors. Volume sensing receptors present, volume sensing receptors are present. Now what these volume sensing receptors are doing, they are all the time sensing the blood volume. Now more blood volume is coming, right? Now this more venous return is going to stretch the atria. Okay, they are going to stretch the atria. Now whenever the atria are being stretched, now the volume sensing receptors are going to be activated. When volume sensing receptors are activated means what happens? Now the atria are communicating to the central nervous system. More blood volume is there. More blood is coming to the heart. Okay, more blood is coming to the heart, something like that. Now, see, now this atria, yes, they understood. More volume is there. Okay, more sodium is there. Now this more volume is because of more sodium. Now what this atria will do? Now this atria, yes, they will communicate with the central nervous system. That reflex we will discuss later. But now, for now, see, this atria are going to release a substance called as atrial natriuretic peptide. Okay, atrial natriuretic peptide. Okay, now this atrial natriuretic peptide, what it will do? In the name itself it says the atrial natriuretic peptide produced from the atria. What they are doing? Natriuresis. Okay, natriuresis. Natriuresis means sodium loss in the urine. See, simple, right? Now unnecessarily the sodium is coming into the body. Okay, unnecessary amounts of sodium is coming into the body. It is increasing the blood volume. So what your body have to do? Your body have to counteract. Your body have to produce the counter-regulatory hormones. What is the counter-regulatory hormone now? The counter-regulatory hormone which is getting synthesized here, which is getting produced here, is the atrial natriuretic peptide. Now what this atrial natriuretic peptide will do? It will cause polyuria. See, simple, balancing. More volume is there inside the body, which is not good. Which is not good for the heart. So now more urination. This patient is going to produce more urination. Polyuria will be there. Along with that, most of the sodium, more sodium is going to be excreted. So natriuresis, atrial natriuretic peptide, more sodium is lost in the urine. So in Conn syndrome, what is happening? Aldosterone escape phenomena. Even though aldosterone is there, see, even though aldosterone is there, but still sodium is excreted in the urine because of atrial natriuretic peptide. So this is aldosterone escape phenomena. Even though with the presence of aldosterone, sodium is escaping out of the body. Sodium is going out of the body, excreting out of the body because of the atrial natriuretic peptide. Okay, so this is aldosterone escape phenomena. Now we can say that aldosterone is trying to reabsorb the sodium. Atrial natriuretic peptide is trying to throw the sodium out of the body. So exactly opposite action. So what are the antagonists? So the aldosterone is physiological antagonistic of, okay, it's a physiological antagonistic of atrial natriuretic peptide. Aldosterone increases the sodium reabsorption. Atrial natriuretic peptide, okay, which is produced from the atria, it will excrete the sodium out of the body. So aldosterone and atrial natriuretic peptide and even the brain natriuretic peptide. Don't think that brain natriuretic peptide is coming from the brain. So the brain natriuretic peptide is produced from the ventricles. So atrial natriuretic peptide or brain natriuretic peptide, both are working same. Both are working as the same. So both are going to increase the sodium excretion, causing polyuria. Aldosterone reabsorbs the sodium. So aldosterone is a physiological antagonistic of this atrial natriuretic peptide or brain natriuretic peptide. Okay. Now if someone asks you that what are the functions of atrial natriuretic peptide, you know it. Atrial natriuretic peptide increases the sodium excretion. Yes, true. If increasing the sodium excretion means simply decreasing the sodium reabsorption. True. And what it is doing? Not only that, this atrial natriuretic peptide is also a vasodilator. Especially this atrial natriuretic peptide, not decreases, it causes afferent arteriolar dilation. It causes afferent arteriolar dilation. Why afferent arteriolar dilation? If afferent arteriole is dilated means, okay, if afferent arteriole is dilated means more blood is going to enter into the glomerulus, more hydrostatic pressures are generated. More hydrostatic pressure means more filtration, more GFR, more urine production. Okay, the volume of urine produced is more, so polyuria. So afferent arteriole, by causing the afferent arteriolar dilation, okay, it increases the urine production. Okay, it increases the urine production. Okay, so these are some important points which I want you to know regarding the Conn syndrome. Now with this, the topic of aldosterone is completed. Okay, aldosterone and abnormalities of aldosterone are completed. So the important abnormalities of the aldosterone, one is the Conn syndrome. Yes, we have discussed, and one more important abnormality about the aldosterone, that is a Liddle syndrome, where even without the aldosterone, the epithelial sodium channels are working. So that also completed. So with this, we are done with the topic of aldosterone, and the next video we will start with the topic of antidiuretic hormone, the functions of the antidiuretic hormone, the pathological integrations as well as the pharmacological integrations we will see. Hope the video is helpful. Thank you.